my Grizzlies shirt. They did not make the playoffs this year, unfortunately.
No.
Yeah, that they're not showing the face because they are.
Everyone, my name is TJ. I'm one of the fourth-year med students at Baylor College of Medicine, Houston, Texas. Unfortunately, I fear for my Rockets might be eliminated pretty soon, but I can only hope Chris Paul doesn't have another good game. So I'm happy to be here.
Oh, I'm sure Houston is decompensating right now after last night's game. Okay, Anne-Marie, just briefly introduce yourself again. Many people here know you, but just.
Hi, my name is Anne-Marie Kumfer. I recently graduated residency and am now working at UNC as a hospitalist. I still probably view myself more as a resident than a hospitalist. And I just love participating in things like this, continuing to learn. Brings me so much joy to learn from everyone.
Okay, and we brought in Kendra Titer Abraham, known as Kiki to all of us. Kiki, why don't you introduce yourself?
Sure. So yeah, my name's Keandra Titer Abrahams. I go by Kiki. I just completed my first year as hospitalist. I split my time between the hospitalist group at UAB as well as the general internal medicine division, where I do some teaching on the general medicine teaching service. Dr. Centor was alluding to some of the projects I'm involved in. One is an enhanced clinical skills track where we teach a subset of residents how to improve their clinical skills. And most recently we had an event on where we did an OSCE-like experience for them where they got to practice their skills in front of faculty and get real feedback. So that's just one of the things I'm involved in, including some diversity inclusion efforts. So I'm happy to be here. Great. And when Alonzo gets here, we'll all razz him in some way. So you're on night float and you get a page from the nurse that Mr. Jones has a blood pressure of 180 over 110. So we'll let TJ go first because he's a medical student, and then Natasha can go after that, and then our experts, and the hospitalists are much more expert than me, but I'll do a little guidance of where we ought to go. So TJ, what are you thinking about when you see this situation?
All right, so high blood pressure. First, I need to take a deep breath and just know that you should only take urgent action if it happens to possibly be a hypertensive emergency. So I think first thing you need to do is just recheck the reading manually, and also check the other vital signs to see if there's any relation between the blood pressure, temperature, heart rate, breathing rate, just to see. And also see if there's any vital sign trends. Like, is this a brand new high blood pressure, or is this possibly a patient that's a cardiac patient, so they naturally run high blood pressure? So although 180s is definitely should tip your hat off that you need to pay attention to this, especially at night. And probably just knowing on the back of your head, this is borderline between being a hypertensive urgency and possibly being uncontrolled. Just need to keep things in your mind as you talk with the nurse, go into the patient's room. Just think in your mind, you need to look out for really bad signs. So thinking about, brain can be affected, your eye can be affected, heart, renal system. So brain, you think about, is there any altered status you expecting to see, or any changes in vision, papilledema, heart? Does this patient have any history of chest pains, or is a patient in for heart failure? Is there any recent EKGs, shortness of breath? I think the last one before you actually walk into the room, just think about renal. So how's their urine output? Is there any, how's their BU and how's their creatinine? Is there any hematuria? Is there any edema? So I think probably those are the main things. I think it's hard as at least medicine or resident, it's just hard not to freak out about this, but they firstly just recheck the reading and see if this is something that really needs your attention. But yeah, I think that's what I initially think about.
Okay, so that's the very nice discussion from the fourth year students. Now that you're actually an intern, Natasha, what would you add to this? What would you, is there anything that you would change in this discussion? How do you think about it?
So he brought up a lot of really good points. I thought that was really detailed. So I agree that I would first want a recheck, as well as the other vitals, and maybe a little bit of history on the patient. Just coming off night float, we at least get a couple of lines about what this patient is in for and what medications they're on. I think the biggest thing for me would be, is this new onset, or has this been going on for a while, slowly creeping up? The other thing, I would really want to know cardiac history, any history of ACS, what else? Also just basic labs, I think, check for end organ damage. I think depending on how long the patient has been this high, if they just came up to 180, probably be a little bit less worried, but I would still want to check just liver, kidney function, and then lay eyes on them as well. Are they having any symptoms, including chest pain especially? I think that would be the biggest thing that I would be worried about. And then when was the last time they got their medications? Because I think I was actually on night float last month, and a lot of times it was like, oh, they're actually due for their medications within the hour. But 180 is probably higher than goal.
Certainly higher than goal.
And a lot higher than goal.
The question, and y'all are getting around this, is when do you need to treat and when do you need to relax and let the daytime team figure it out. Kiki, how do you think about what they've said, and now that you're taking care of patients yourself? I'm sure you've had this call when you're on the hospitalist service, and I know that when you were chief, you were an attending and you would teach residents about this. So how do you see this?
Yeah, I really thought you guys brought up a lot of great points. I like the first point the most, sort of check your own pulse first, or sort of take a deep breath, because I really think our job as physicians in the hospital is to bring a sense of calm and stability and sort of clear thinking to a problem that's presented to the medical team as a whole. And I really think that goes a long way in providing the patients with great care. So that is the first thing that I do. I think contextualizing the patient is one of the most important things you can do up front. For example, thinking about situations where higher blood pressure may be permitted. Maybe a person's coming in with a stroke and there's permissive hypertension that's being allowed to increase perfusion. I think Natasha brought up a great point about how long has this been going on? Is it acute? One thing I really like to do is when I get the call, I like to figure out, do I need to go see the patient, right? Because night float is busy, you're admitting, you're seeing other acute cross-cover issues. So thinking about, do I need to go lay eyes on the patient could really be determined by what type of information you get, either from the person calling you on the phone, so asking the nurse vitals, such as TJ said, symptoms that the patient is having up front can really let you know whether you need to go lay eyes on them or not. And then taking a quick look at the checkout, which is really important, which is why I'm a big proponent of having a clear and concise checkout and patient summary, so someone can scan, know exactly what's going on with the patient within a few seconds, and be able to decide, is this something that is expected based on the patient's clinical condition, past medical history, et cetera, or is this a new and acute condition that I need to be aware of and potentially look into the chart a little bit deeper and or go see the patient. So that's kind of where I start.
So I'm gonna reflect on what you said so beautifully. And the very first thing you said, I think, may be the most important thing in all of these night float situations, and that's contextualize. Who is the patient? Are they on medications? what has been happening to the patient today, and there's so many variables that you can't just get by the telephone call or the page. And Ree, you have a lot of experience in this. Do you have anything to add or re-emphasize?
Mm-hmm. I would say it's one thing to keep in mind is it's probably one of the most common pages you get in the hospital. I read an article today that said about 72% of patients in the hospital have hypertension. And I would not let a number itself freak you out, because a number can sound really scary, but it's always, as everyone else has said, putting it in the context of the patient and their baseline and everything. Being in the hospital is stressful. A lot of times there's pain, there's a lot of other factors. And so I think really the symptoms versus no symptoms is the main thing I try to look at. You know, is there any, like, a new oxygen requirement or chest pain or vision changes or anything, like a really bad headache? A lot of times someone will have a mild headache. So I would not say a mild headache. I would not call that, you know, hypertensive emergency. But if someone said, I'm having this really severe headache that's different from anything I've had. So, you know, kind of breaking it down, is this symptomatic versus asymptomatic? Because if it's asymptomatic hypertension, well, really both symptomatic or asymptomatic, if we lower it too quickly, we can actually do harm. And so usually if it's not symptomatic and I don't see any other concerning things, I don't treat it outside of a few select scenarios, like aortic dissection, you would treat aggressively, or if someone had gotten TPA for a stroke and you needed to keep the systolic less than 185, or if someone had a recent bleed, a big bleed or something, and you wanted to keep it down to help prevent rebleeding. So really put it asymptomatic, symptomatic. Is there a scenario where it's really important to treat this? And then otherwise, I think you can kind of take a deep breath and don't feel like you have to treat it really aggressively and lower it really aggressively just based on a number alone.
So this is, y'all are doing such a great job. Let's see if we can sort of put together sort of a flow chart. You get the call, you quickly pull up the medical record and find out who the patient is, look at your sign out, but there's probably a lot of things. Once you get a call, there's more than just the sign out. So for example, the sign out might not have the list of medications. And in the podcast that I did with Charlie Ray and Tim Anderson, they said they mentioned it's amazing how many times the patient did not get their meds that day. So the patient came to the emergency room first thing in the morning. They didn't get their meds. They were ordered for the next day. And so now they've been 36 hours without meds, and you get a call at 2 a.m. So did they get their blood pressure meds that day? Are they on blood pressure meds? Did they get aggressive IV fluids? Are they in a lot of pain? Is this a pain admission, which can bump it up? What's their blood pressure? And these are all things y'all have said. I'm just restating it. What is the course of their blood pressure since they've been in the hospital? It's different for somebody who's been here for 6 days and someone who's just admitted that day. And that's what Kiki was talking about, was contextualizing the patient. The number itself doesn't mean anything. This really brings up one of the things that there's the wonderful article that Charlie and Tim wrote in the Annals of Internal Medicine on management of hypertension in the hospital. And for years and years, and this goes back to when I was an intern resident, we developed this nondescript thought of hypertensive urgency rather than hypertensive for hypertensive emergency. So hypertensive emergency is easy. There's end organ damage. But is there such a thing as hypertensive urgency? You were just on night float, Natasha. What do you think?
Sorry, can you repeat the last part again?
Yeah, so when you were on night float, did you and your resident or anybody ever discussed the concept of hypertensive urgency, or is that still something that house staff talk about?
Yes, I think we talked about it more in the context of hypertensive urgency versus emergency, and you worry more in emergency because you have end organ damage. And a lot of times I think, especially on night float, when you're not the primary team and you don't know the patient as well, even as you pull up their chart and read about them, I think there's less urgency to treat hypertensive urgency, and you want to think about why it's happening. The cause, like we talked about, is there some reason for an acute increase, or is it they just haven't gotten their medications? And another thing I think is important as well is, where are they? Is this somebody that was admitted by the day team at 3 p.m. and you came in at 8 p.m. and they've just been in the emergency department this whole time? Or is this someone that's 2 weeks into their hospitalization? But yeah, kind of the distinction between urgency and emergency, I actually remember talking about with Kevin Schwalbach, because I admitted a patient, and we were talking about how headaches, I think, are not actually necessarily considered emergency. It's if they're having altered mental status, if you're going to call it hypertensive emergency.
So that's the point that Anne Marie was making, and maybe we can remake that. There are people who say that we should not use the term hypertensive urgency. Mm-hmm. That if it's not a hypertensive emergency, then the biggest thing we need to do is make sure we're calm and figure out how to calm down the nurse. Because the nurses are the ones who get very excited. Anne Marie had a great tweet once we announced this. Tell them what your tweet was, Anne Marie. You have to unmute yourself.
I said the answer is never IV hydralazine, which I probably should have put a little asterisk, because you should probably never use never. But the answer is 99.9% of the time, not IV hydralazine.
Right. And then somebody responded that at the hospital where they were a resident, the nurses called and said, can we give the IV hydralazine for that blood pressure? And so I think the point you made was a very important one, and a lot of people obviously agreed with that. That was standard of care for 20 years. It's not till recently that people have stopped doing that. And IV hydralazine is really dangerous. Kiki, during your residency, was there a change during this time in how you thought about IV antihypertensives?
Yeah, during residency, you really wanted to minimize pages. And so I was a fan of having a list of favorites. And one of the favorites that I had was IV hydralazine, and the comments give for blood pressure systolic greater than this. And I moved away from doing that because, one, I'd like to actually know when the patient's blood pressure is elevated so that I can do all the things we talked about, evaluate the context of the patient, the chart, and figure out, do I need to act? And two, I don't want medications like that being given excessively when obviously there is no need. And that's exactly what we're talking about with this term of hypertensive urgency, which really kind of doesn't exist. And so one point I did want to make is that as we know, the difference between hypertensive urgency and emergency is end organ damage. But the only way you know if it's emergency is if you get information to figure out, is there end organ damage? And so I want to remake my point of making sure you partner with the nurses who are calling you to figure out, if they're going to page you with this information, then you have to ask them next, how is the patient? Go through a few major symptoms that is associated with hypertensive emergency. And if that's not there, then it could be a teaching point for the person calling you. Thank you for letting me know. We're actually going to just keep an eye on it, maybe give him or her his home medications earlier. But as long as they're asymptomatic, there's no reason to treat it urgently. And I appreciate the call, and keep me posted if anything changes. That way you've you've made a good clinical decision, you've provided education for staff, and you've created a partnership with staff to say, hey, I'm concerned with, as you are, if X, Y, and Z happens. So make sure, you keep me up to date. I really appreciate that.
So since we call this Unremarkable Labs, and we really haven't talked about labs yet, I'm just going to throw this out. So we'll let you try, TJ. Under what search situation are you going to send off labs now? And what labs are you going to send off? And I don't know that there's a right answer to this question. I'm just really interested in what you think, what Natasha thinks, and then what our hospitalists think.
Oh, for what initial labs?
So you get called 180 over 110, you go by, and the patient is conversing, really has no complaints, no headache, no chest pain. The patient has been running a little bit high blood pressure in the hospital, has a history of hypertension, doesn't have any heart failure or anything like that. Under what would get you to order labs? And it's 2 o'clock in the morning now. This always happens at 2 o'clock in the morning. This does not happen when you first get there. This always is, you're thinking about taking a nap, and this interferes with your nap. The only thing that bothers you more is when someone calls for a sleeping pill as you're trying to get a nap. At least back in my day, that's it. I would go around and make rounds before I was going to lie down, make sure all the IVs were running, because we had to start our own IVs back then, which y'all don't have to worry about now. But that was actually a big deal, and make sure that everybody had a sleeping pill ordered in case they wanted, so that their needing a sleeping pill didn't cause me to have insomnia.
Yeah, I actually probably have to defer. I wouldn't know what I'm leaning towards not getting labs if there is an indication.
So let's put it this way: is there any lab test that would push you on on treating it? So so you may order it, or you may look and see if they've gotten that recently, or you may see whether or not it's being done the next morning. You might not have to do it at 2 a.m., but if they're going to be drawing labs at 4 or 5 or whenever they draw labs, and it's already ordered, then you say, okay, well, that's pending.
Mm-hmm.
I don't need to get so excited. But what labs are important here?
Sure. So if you want to check for end organ damage, renal, so getting your BUN, getting your creatinine, perhaps BNP. I think you mentioned there's no indications of heart failure or chest pain, so I don't think there's indication to order an EKG. Maybe I'm not too sure there. I wouldn't know of other labs to get necessarily. CBC, I don't think there's an indication here for that, so I think yeah, I probably defer to people with more experience.
Well, that's why you're here, and maybe you'll learn something here in a minute or two. So Natasha, I'm sure you got this call several times last month. Did you ever need to order labs?
I would not pull the trigger on labs. I think it's 2 a.m. Depending on if you're at UAB or at the VA, they're probably about to get, almost everyone gets a CBC and BMP. Anyway, considering the patient's asymptomatic, not having chest pain, I don't think there's an indication for an EKG at this point, especially if they have hypertension and this is just kind of a little bit higher value than normal. I would not yet pull the trigger on labs. I would make a note of it and tell the day team that if it's something that stays elevated despite their usual regimen, to follow up on the morning.
Anne Marie, what would you be doing if you were the teaching attending the next morning?
I think just, if it's a chronic thing, then I really don't think that they need anything other than, titration of the medications, because some people run at that and that will be consistent. If it's an acute thing, I would want to make sure that there was a creatinine in the chart. If it was kind of like sudden onset, I'd want to go through the clinical scenario and kind of go through my possibilities. If there are other signs of, hyperthyroidism or something like that, maybe think about getting a TSH. But most of the time I end up, if it's an asymptomatic patient that's completely stable, end up not doing anything, just let them get their usual labs. And a lot of times it will just kind of come down on its own. So I'm not very aggressive.
Great. So let's finish this scenario up with Kiki. You sort of open this up. What is your branch point for I really need to go see the patient, or I got so many other things to do right now that I'll just reassure the nurse over the phone?
Yeah, so really my branch point is there something that is new or worsened in the patient that could be related to the elevated blood pressure? So typical scenarios I see, I actually had an example of a patient that came in with a little high blood pressure, chest pain, had a history of an MI, wasn't taking his medications, had some stents placed and wasn't taking his DAPT, doing antiplatelet therapy for his stents. And so we were sort of going down the route of an MI, but his blood pressure just kept getting more and more elevated, 150s, 160s, 170s. And so we finally pulled the trigger and scanned him, and he had a huge dissection. And went immediately for surgery. And with the elevated blood pressure, he was having this worsening chest pain. And so, I think for me, when I get the call from the nurse and I ask those screening questions, if they're telling me, the patient is having new chest pain or worsening chest pain than what they had on admission, if they were maybe a little confused before, but they're more confused, or new confusion, or now they have a new oxygen requirement, or their breath looks labored, then those are examples of signs that would make me want to go evaluate the patient myself. And then from there, I let my history and physical exam guide me on the next steps. If I evaluate the patient and they have a headache, as Anne-Marie mentioned, typically I'm not going to scan the patient. I would probably at that time perhaps try a little IV medication to see if that helps the headache. And my management for that would change if they had a headache and some new weakness or new numbness and tingling, then that would make me pull the trigger to scan the patient. So I sort of let my screening questions guide me to figure out if I need to go evaluate the patient. And then from there, my history and physical exam, figure out what I should do next.
I think you raised a really interesting point with that example of sometimes we need to have someone check the blood pressure in both arms. And so, Anne-Marie, let's let Natasha do this. What would make you ask for blood pressure in both arms?
So if somebody who had otherwise been stable and been pretty normotensive through the admission had sudden onset of tearing chest pain, kind of radiating to the back, that's more classic. But honestly, with new onset chest pain and, like Kiki said, like slowly creeping hypertension, it's not chronic, it's acute. I think there's been one time that I've asked for it, and it was like a similar scenario where they had new onset chest pain in a normal EKG.
Yeah, it's interesting. If you go back and look at the data, we actually wrote up a clinical problem-solving case for Journal of General Internal Medicine on a very unusual presentation of dissecting aorta, and where a lot of errors were made initially. And when you review it, atypical presentations happen a lot. I think it was like 30 or 40%. So our typical presentation of aortic dissection is not what you see all the time. And so I think that trigger there of this blood pressure doesn't make sense, given everything else you know about the patient, might be part of your physical exam, might be, let's take the blood pressure in both arms. Or if you go into the rooms, check for radial pulse lag, which is really pretty easy to do. So does anybody in the chat have any questions before we go on to the next scenario? And Sean, since you're our recorder, did you have any questions, or one of our great chief residents?
Can I just ask a quick question?
Sure.
How do people address getting the blood pressure in both arms? I think it can be kind of it's a good simple test, but we know that about 20% of the normal population will have a gradient of systolic greater than 20 between the two arms, and it's relatively insensitive. So perhaps you could be falsely reassured. So how do people incorporate that data into their clinical decision making?
So I'm gonna let Kiki go first, and she just had this, and then I'll tell you how I think about it. But since you just had a patient who had it, Kiki, what made you go down that road?
Sure. I think it was the clinical history and the context in which the patient was admitted. It was a little bit of anchoring on our part, where the scenario seemed to fit MI, but initially we were treating him with nitro sublingual, nitro patch, and he just wasn't getting better. And for someone with fairly typical chest pain, obviously we know nitro is a great option. And so and also high blood pressure doesn't often follow necessarily an MI, at least consistently. We're talking about into day 1 or day 2, right? And it should improve with nitro potentially. So the clinical picture didn't fit, and that sort of led us down this rabbit hole of what else could it be. And with the acute worsening of the chest pain and acute worsening of the high blood pressure, it just made us think, what is the next step probably to scan this person. And so I guess in answer to your question, clinical context is key in figuring out, is the differential in blood pressure from left to right arm something I need to pay attention to, or is it a red herring that's not related to the patient's medical care at this time, and just part of the general population, a small percentage of who has that thing.
And the case that we wrote up many years ago, I was making rounds one morning, and it was sort of slow, and my resident had been moonlighting on the hospital service the night before, and he had seen the patient, and the patient actually had both an MI and an aortic dissection, and the MI was secondary to the aortic dissection. And what was interesting when we presented it to one of our excellent clinicians, Gustavo Hudebert, as a clinical problem-solving case, and part of his must-dos in physical exam is anybody with chest pain, even if it's not a good story for chest pain, you got to get the blood pressure in both arms. That's what he teaches. Now, that might be overdoing it, but maybe it's not overdoing it, because you'd hate to miss an atypical chest pain, which aortic dissection can be. There were some other clues in this case, but and it was a very wide difference in the case that we wrote up. Did you get blood pressure in both arms, Kiki, in your patient?
Oh, we actually whisked him right away to CT, so we did not check.
You didn't have time to get the blood pressure because you went to CT. Yeah.
We just checked his pulses. He did have diminished pulses on one side, and that with everything else sort of painted the picture to stat CT.
Yeah. And that's a nice part of the physical exam that we forget. I think we're all taught at some time to go ahead and check both radial pulses and see if they're beating at the same time and of the same strength, but we don't focus on that quite as often. But that is part of a chest pain exam. Well, I hope everybody did pretty good with that one. So here's your next call. So Natasha, you're just sitting there. You're almost caught up. You have a few things you have to do. You're hoping that you don't get any more admissions. And you get called because the nurse says the patient has a blood pressure of 90/60.
Okay, so I first would want a repeat. Would like to know the patient's baseline. I'd probably jump into their chart really quickly and see, is this a new acute decrease? Or are they someone that usually runs at like 100, 110 systolic? I'd look for, are they tachycardic or not? And then I guess while I have the nurse on the phone, I would ask her, are they symptomatic? Are they lightheaded? Are they febrile? Hypotension is one of those things that can be caused. There are many, many different causes. And I guess I would want to know a little bit about the clinical picture of the patient, because they're definitely, if it's something acute, there are a lot of different things on the differential that could kill the patient, and you want to rule those out first. I guess kind of the.
I'm going to stop you just for a second. I'm going to get you, and then TJ, you be thinking about this. Why don't we quickly develop ischemia for this blood pressure? So let's just start naming the things that we're worried about and the things that we're not worried about. Because if we know that, then we know how to evaluate the patient. So we'll try to put together a list, and Sean is going to take care of the Moreau. And I just wonder, was Moreau named after the great artist or not?
I have no idea how they got the name.
I actually went to his museum when I was in Spain last year. I hope that one of these days I can go back to Spain. I hope one of these days I can travel anywhere. Okay, so Natasha, give me a couple of things that cause low blood pressure that are going through your mind.
The biggest thing in the inpatient setting, the most common, is usually sepsis. The next big thing that I would worry about, just common things being common, are they bleeding from somewhere, hypovolemic? And then all kinds of different things. Do they have a PE? Do they have a pneumothorax? Do they have a pericardial effusion that turned into tamponade? Those are probably like kind of the first things I think about. Or are they just volume down because they were NPO for a procedure all day and haven't drank water? And
or 2 days in a row, which unfortunately sometimes happens. TJ, do you have anything to add to that?
Oh no, I was thinking the same thing. Thinking about shock overall, distributed cardiogenic, hypovolemic. Thinking about pneumothorax, PE. Yeah, nothing to add.
Anne-Marie?
I think an important thing to differentiate is thinking about, are they in shock? Because hypotension does not equal shock, and shock does not equal hypotension, but certainly someone who is hypotensive could be in shock. So looking back at their baseline blood pressures, because certain patient populations, like patients with cirrhosis, tend to run lower at baseline, or sometimes you'll just get like a smaller person that just runs lower at baseline. And so kind of what's the difference from the baseline? Was this when they were just fast asleep? Because oftentimes the blood pressure will be a little higher, when they're sleeping. Or was this when they were like awake and alert? And then looking at the other vital signs as well. And then usually in this case, 90 over 60, it depends. If that's their baseline, then I don't examine them. But if it's a significant change, I'm much more prone to examine a hypotensive patient compared to a hypertensive patient. So usually I try to go examine them, look at their urine output, look at their mental status, try to assess if they're perfusing. So I'll see, are they warm or cold? And I don't feel they're like fingertips or their feet, because my hands run extremely cold. So if someone felt my hands, they might think I was in shock. But the elbows, the knees, kind of the lower legs, making sure they don't have like peripheral arterial disease there or something like that. And then do they look volume up or volume down? And then if I have any concerns that they're showing signs of a shock state, or it's something new or different, then I'm kind of going through my shock buckets. Is this distributive shock? Do I see signs of that? Like if they're warm and kind of like diaphoretic, or is this hypovolemic shock? And then I go through my buckets of hypovolemia. Could there be some sort of mechanical obstruction, thinking about the lung sounds, thinking about looking at the neck veins, or does this look cardiovascular? So just kind of trying to go through everything and assess, like, is this is this life-threatening? Does this need to be addressed immediately, or is this someone that this is near their baseline?
Kiki, you're shaking your head like it's really hard to add anything, but who would you not go see?
I think it's been said, anyone where this is their baseline, and
So
it's not far off.
So on what service are you most likely to not get excited by a blood pressure of 90/60?
I would certainly say the liver surface, and depending on the patient, the cardiac service. If you think about a lot of the heart failure patients, the target blood pressure is 90 to 100 for a lot of them. And so those are not patients that I typically worry about if that is their goal and they've been sitting at that goal for part of the hospitalization or attempting to reach that goal through medications, as based on their primary team. But of course, anything new, then that definitely warrants the inpatient in-person evaluation.
And we'd certainly be excited if the person before you had given IV hydralazine for hypertension and now they had a blood pressure of 90/60. Because that's why you don't give hydralazine. Right, Anne-Marie?
Yes, definitely. I think about like 20% of patients who get IV hydralazine actually have adverse effects because they go too low.
Right. So you want to so you have to look at the meds. So let's see if we can summarize this. We want to make sure that they're not in shock. Everybody's going to yell at us if we miss sepsis, right? Everything is sepsis now. And so is this a patient who might have sepsis? So your checkout really could help you, because if you know the patient has some kind of infection and then they drop their blood pressure, that's something different. I really like that the second thing that Natasha mentioned was bleeding, because that certainly is a non-sepsis reason to get these problems. I think you all implicitly said that. I don't remember if you explicitly said it, but I think that if I get called for a low blood pressure, the next thing I want to know is what's the pulse, and then I want to know, are they on a beta blocker, and so I can interpret the pulse, because low blood pressure and new tachycardia gets me a whole lot more excited than new blood pressure and lack of tachycardia, unless they're on a beta blocker and they just can't go up. Does that make sense, Kiki?
Yeah, absolutely. I think knowing the medications, not just the blood pressure medications that they were given maybe to over treat their blood pressure, but the ones they were on and stable on the hospitalization now may kind of confound the picture of them getting increasingly sick, particularly as it relates to sepsis and other causes of low blood pressure. And so I think keeping that in context of how should you approach treating the patient is really important.
So have you had this scenario? A patient comes in, known hypertension, comes in, their blood pressure is a little bit up. You reorder their outpatient meds and their blood pressure tanks. Why would that happen, TJ?
Possibly taking too much of the medication.
Well, so in the hospital, we gave exactly what was ordered.
Oh, okay, in the hospital, okay. I'm not sure.
I think you're onto it, but being a fourth-year student, you probably haven't run into this yet. Natasha, have you run into this?
Yeah, so are they actually compliant with their medications at home?
Right.
Because if they're not and you give them what they're prescribed, you can tank them easily.
Right. So what happens in the outpatient setting is a lot of times we readjust their blood pressure medicines based upon the blood pressures we get, and we ask them if they're taking their medicines, and we don't always do a good job of making it comfortable for them to tell us that they're not really taking their medicines. And that's where we have to really be careful about our bedside manner and the way we talk to patients so that we can get the truth of that. So
I'll just say one trick that I learned, because I found that for example, a patient is normotensive when they arrive, but they're on 3 blood pressure medications at home, I obviously like to make a real-time decision to hold those medications because I know if I restart them, I'll bottom the patient out. But I don't want someone who may be seeing the patient the next day, particularly in hospital services, if I'm rotating off at some point, that person may not be aware that they're on home medication. So I like to do my med rec with the patient's medications at home, adding them. And so I go through the med rec, I pretend to start them, and then immediately when I finish the med rec, sign the orders to have the medications appear in the chart, I'll suspend their home medications so that if they then become hypertensive throughout the hospital stay, then someone can just unsuspend 1 or 2 or 3 of their blood pressure medications and start them back in a way to better control them. But I like to do that. That way they're aware that they're on medications at home, and they need to keep an eye on their blood pressure to figure out when to restart them.
And every now and then patients will be so adherent to their medicines that we give them the medicines in the hospital, but they brought their medicines from home and take those also. And I promise you that happens. And Kiki's shaking her head like she's seen this. Have you run into this, Anne Marie? Either one of those situations?
I don't think so.
So I think, so Kiki's been doing the hospital service for a year now, and I'm sure you've had a lot of patients. So if someone comes in with a blood pressure of 140/90 and they're on their medicines, you're less likely to suspend the medicines than if they come in at 120/80. Is that what you're saying, Kiki?
So it sort of depends, and depends on what they come in for. And someone sort of posed this on the chat. If I know they're coming in septic and they have the propensity to tank in the middle of the night or sometime in the next 24 hours, I'm comfortable with a little higher blood pressure in the 140s or 90 over 90s. Let them sit there for a little while and see, which way they go. Patients will usually declare themselves after 24 to 48 hours. And as long as it's not uptrending, I'm comfortable with that. And I think we need to allow ourselves to be comfortable with a little higher blood pressure, considering there's a lot going on in the hospital, and that the patient's course may change. And last thing you want to do is give them something that could eventually be harmful, depending on whether they crump. So
I guess the last thing that we ought to see if we can put together a good thought about. I know at UAB it's called a cat call. Is that a common phrase all over the country? So Natasha, can you explain what a cat call is?
Yeah, I think at the VA we call it a cat call, and at Maine we call it a MET. It's usually when a patient has decompensated. So depending on, I know at the VA, I was there last on night float, so I remember a little better, but if they meet a certain criteria based off of their vitals and when the nurses check them every 4 hours. So I actually got notified about multiple cat calls after they'd already been called for concern for sepsis or new oxygen requirement, things like that.
So it's sort of a preemptive way to say, do they need to be in the unit?
Yes, and usually a pulmonary fellow, depending on if you're at the VA or UAB, will come with a nurse and an anesthesiologist ready to intubate just in case. So
let's say it's up to you. What about the hypotensive patient is going to trigger not just managing the patient, but getting the unit involved? So since you were just on, Natasha, I'm just so happy that we have somebody who was just on the night float service. This makes this great.
Yes, very good learning experience for sure. So if they are just hypotensive and the nurse says, they seem maybe a little altered, or they're very symptomatic, or they feel very warm, I would probably go lay eyes on them. I would say if they spike a fever, I would probably go ahead and get and they're tachycardic, I would get the ball rolling on like a sepsis workup, but I wouldn't necessarily go ahead and trigger a MET unless I'm worried about them acutely decompensating. So if they're suddenly hypoxic to, 84%. And this is someone that has no baseline pulmonary history, or they're unresponsive and they had been previously, or they're tachypnic and you can see all of their accessory muscles, things like that.
Anne Marie, do you have comments about that? I'm sure that during your residency, you had plenty of such incidents.
Yeah, I think that's a great framework, Natasha. I feel like usually when you go to the rapid, you like as you're walking in, as time goes on, you kind of get a gestalt of how things are gonna go. But I certainly think, when you're seeing that patient, what's the map? In this scenario, 90/60, that's a really good map. I don't know exactly off the top of my head, but probably around 70. So kind of above, like 65 is the threshold that I'm getting really nervous about, and I'm thinking about like I need to intervene rapidly, especially if they have other signs of shock or decreased cognition, if the nurse says they're not producing much urine, or other signs that they're not perfusing well. So, and then just like seeing how they look overall and what their other vital signs are. If you're worried, definitely getting a lactate to see are they getting enough oxygen to their tissues, or do they have tissue hypoxia, are kind of some of the things I look at, like what's the initial blood pressure, what is the patient status, and the other vital signs as well, as was mentioned, if they're tachycardic in their 130s, they're working really, really hard to try to maintain their blood pressure. So obviously something else is wrong.
So what I hear you say in between all that is one of the things that I think we all learned during residency. We're usually not quite as good when we're interns as when we're senior residents, is what sick looks like. And in this situation, you almost have to go lay eyes on the patient, and it's almost intuitive that you look at them and there are things that make you worry, and it's hard to explain that until you've seen a lot of sick people. Kiki, you're shaking your head. I mean, I don't know how to write that down in an article, but I know it. I mean, I've walked into rooms as the attending on rounds that says, I don't like the way this patient looks. And I can't tell you exactly what it is. Since y'all are doing this study on bedside teaching, is this just, we know what sick is?
Well, I tell all my interns that I work with is that your main goal for intern year is to learn sick versus not sick. All the other medical stuff will come, but if you can learn that, you have a good solid footing for the rest of your medical training. And to me, sort of, as Anne-Marie already pointed out, as well as Natasha, really let your physical exam and history guide you into figuring out how sick is this patient and what can I handle on the floor. And that may be different based on the unit, based on the hospital. Things that we can handle on the floor at UAB, as residents find out, is very different from what we can handle on the floor at the VA. And a lot of that has to do with nursing staff and manpower, technologies available on the floor. You may not have an iStat on that floor. You may not, have certain equipment on that floor to care for the patient. You may not have continuous monitoring available. So when you get ICU involvement really depends on how sick is the patient and what can you manage on the floor. With that being said, I don't want to reiterate all the same points, but to me, the things that stand out for an immediate CAT call or MET call would really be sort of altered mental status, really bad hypoxia, really over 6 liters requirement to keep SATs up, and sort of tachypnea in a way where the patient really looks like they're working to breathe, and oxygen through nasal cannula is not going to suffice. They're going to need some positive pressure to really help them breathe. those three things sort of stand out to me in terms of immediate ICU evaluation. I can handle MAPS sometimes on the floor less than 65 if I can get stat fluids. Is there a pressure bag on the floor? Maybe, maybe not. I can handle some hypoxia under 6 liters. I can handle decreased urine output. I can handle tachycardia even, depending on what it is. But some of the other things I think require stat ICU evaluation.
What about fever spike
Fever
along
spike.
with this?
So that's not, me personally, maybe I'm a little cavalier, but for me, fever spike is not an immediate ICU evaluation. Many patients have high fevers for different reasons. I've seen it with basic UTI.
Well, I was talking about fever spike and low
right.
blood pressure.
Yeah, and for me still, I've seen, I work at Highlands quite a bit, where there's a lot of little old ladies from nursing homes coming in with, fevers and a little low blood pressure. If I can get them some fluids and some antibiotics, they usually turn a corner. So that for me is not necessarily a trigger just yet, depending on how the patient looks.
So Kiki's heard me say this before, and I think Sean has seen me do this. Here's a trick that I learned when I was an intern at the Medical College of Virginia on accessory muscle use. It's really hard when you first start out to see accessory muscle use, and he's no longer alive, but one of the pulmonary attendings who won the Golden Apple Award multiple times when I was a student, Orrin Murin, taught me to feel the accessory muscles. And what he taught me to do is put my thumb on the scalene muscle, and you can feel accessory muscle use before you can see it. If you're having a hard time seeing accessory muscle use, once you feel the scalene contracting, and check this on a patient who has no shortness of breath at all and is clearly not having to work to breathe, and you'll feel no contraction of the scalene muscle. Then go see somebody with COPD or asthma, and you'll see it. And then if it's getting worse, it's a lot easier to see the accessory muscle use after you feel the scalene muscle contraction. And that might be a way to see how hard the patient's working to breathe, is first feel the scalene muscle. And then if you can see they're actually recruiting the sternocleidomastoid and they're recruiting the abdominal muscles, that's the patient that you can be worried about. That's a tip that I learned many years ago. I hope this has been really good for the people in the chat, and I'm going to let TJ. What are the most important things that you've gotten out of this session? And we really thank you for participation.
Yeah, thank you for letting me participate. I think for me, just getting a story about the patient, understanding when the patient came into the hospital, what's happened over a course of days or the day of, if it's the same admission day, and even getting calls from a nurse or anyone for that matter, just making sure to stay calm, understand the whole picture, understanding medication history, what meds have been taken that day, understanding more about vital sign trends, and just having sort of a good thought process running through your head as soon as you go see a patient. Hypotension, you need to definitely lay eyes on. Hypertension, not so much so, unless if you have high suspicion, you need to see the patient. But yeah, I think the biggest thing I took away was understanding symptoms for the patient and time course. But yeah, this is really great. So many great pearls.
So Natasha, this is after your month of night float. Would this have been helpful before your month of night float? And what in particular did you get out of, do you think you would have liked to have had before you started night float?
Definitely. So I think schemas are really helpful. As I guess I'm in my 3rd month of intern year now, but I remember actually Dr. Iyer, who's one of the Pulm Crit docs at UAB, posted a really good schema on shock like the week before I started night float, and I studied that a lot, but this would have been really helpful. I think everything we talked about is things I learned over the course of a month, and with, multiple calls and cat calls and lots of pages. But yeah, I would recommend everyone watch this before you do night float, because there will be a lot of things. And I think the biggest thing is staying calm, because a lot of times you'll get paged about things and then you'll go lay eyes on the patient, be like, oh, they're fine. And I think I've gotten a lot better at deciding who's sick and not sick just from that 1 month.
And Marie, final thoughts when you're going to be working with students and house staff in the future. Well, in what way is this going to help you figure out how to explain these things to them?
I think it's just helpful to talk through it and hear TJ and Natasha, y'all had such great thought processes, and just talk through it and everything and kind of learn like how to approach it together. And I think for every learner out there, and we're all learners in some ways, is that it's always okay if you don't know or you have something that you're concerned about, is to ask someone else to tell them the scenario, maybe have them go evaluate that, and always feel free to call a friend if you feel uncomfortable with the situation.
Yeah, there's always somebody else around that you can bounce a case off of. And even though I'm PGY 45, I still do that. And Kiki, you get the last word.
Sure, yeah, I just echo everything that's been said. And really, to me, as I pointed out, the most important thing is to stay calm. If you are able to do that, then you allow yourself time to think through what might be happening and what would be the next step. And that always serves the patient better than to react without thinking through what would be best for the patient. So, yeah.
Great. Sean, thanks for writing all this down for us. And as our designated scribe, I guess I'll give you the last word.
I was going to say, I'll share it with everybody on Twitter and be able to throw some things out. But I do want to say, I think one of the important things in medicine is making sure you have a coach, somebody who you can talk through your thought process with. So making sure that you recognize and identify who those people are around you, who are able to support you and help you to become a better doctor, is incredibly important.
Yeah, and I always get the last word. After you have one of these situations and you're not sure if you did it right or wrong, run it by that coach and say, should I have done something different? And you are going to feel like you did something wrong on a patient multiple times. And whether you did it wrong or not, because that's just our personalities. So all you're trying to do is get better every time. Thank you all for coming. Really appreciate it.
Thank you for having us.